Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Oncology Today. As today we talk about the management of HER2-positive metastatic breast cancer and a bunch of other things in breast cancer with Dr. Joyce O'Shaughnessy, the director of the Breast Cancer Research Program at Texas Oncology in Dallas, Texas. This is really a follow-up to a program we did with Professor Giuseppe Curigliano, another Oncology Today program which went into metastatic HER2-positive breast cancer in depth. And we thought we'd explore a little bit more and get Joyce's input on some of the things Dr. Curigliano talked about. And we really recommend you check out that program as well. We do webinars all the time. Tomorrow we're going to do a program on colorectal cancer with Dr. Overman from MD Anderson. We'll talk about cell-free DNA and more HER2-positive colorectal cancer as well. Next week, we're going to start a series on soft tissue sarcoma and related tissue disorders with Dr. Van Tine. And then, as always, we're heading out to ASCO, the Hilton Hotel, the big ballroom. We're going to be doing 9 programs, but they're all going to be online if you want to check it out virtually. We're starting out with gastroesophageal cancer, lung cancer, hepatobiliary, prostate on Saturday night. It's going to be real interesting with the recent EMBARK study, ovarian cancer, CLL, myeloma, lymphoma, bladder cancer, breast cancer, and then we'll finish out with renal cell cancer. It'll be a big week for us in Chicago, and we invite you to join virtually. But today we're here to talk to Dr. O'Shaughnessy about breast cancer, and we'll chat for a second, and then we're going to kind of get into HER2 positive. Then I want to find out what Joyce thinks about what's going to be presented at ASCO. But particularly, we want to encourage you to submit cases and questions for us to talk about in the chat room. Joyce, I was just reflecting back. I saw you a few weeks ago. We were at the ONS Congress, annual Congress in San Antonio, and we did, I think, 10 programs there. We flew in 43 people. But one of the most exciting ones was you, because I got a message a couple hours before we got started of Joyce's plane has been delayed. We're not sure she's going to make it. So we had Adam Brufsky already virtually to come in for you. But sure enough, you walked in, there you were. I guess it was a little of an adventure getting there, huh, Joyce?
Yeah, it was, but I never doubted I was going to be there, Neil. I was a little delayed, but I thought we were going to be good. So yeah, I was never worried.
You weren't worried, yeah.
No.
I think you landed like 50 minutes before the program started, but amazingly, you found your way in there. So let's talk a little bit about HER2-positive metastatic disease in this program we did with Dr. Curigliano. And before we get into some of the content, one of the things I wanted to mention, and Joyce, we know that about 30% of our audience are sort of newer to oncology. You've been in oncology really less than 10 years. We have a lot of fellows who use our programs. And, I noticed when I went through Dr. Curigliano's papers, he actually did a paper. He was actually a protege of Dr. Gianni Bonadonna, one of the fathers, really, of breast cancer research, along with Dr. Fisher from the NSABP. He wrote this paper about Dr. Bonadonna, his impact not just in breast cancer, but also Hodgkin's disease and just randomized clinical trials in general. He ends it with hail to a great man and to a life well lived. I remember Dr. Bono was like an Italian movie star, very handsome, well-dressed, come up talking about, he was the one who came up with CMF. And of course, at the same time in the United States, the NSABP was cranking out, I think it was LPAM to start with. But any reflections back on that era, Joyce, when, it was very different than what's going on now? We were just beginning to look at even randomized trials.
Yes, I was the second generation, Neil, because when I went to the NCI to be a fellow, and the folks that founded the field, Johnny Bonadonna had not too long ago left the NCI. Vince DeVita, his counterpart, was still there. So was Vince DeVita, and he was, head of the NCI. Vince and Johnny Bonadonna had put the original combination regimens together for lymphoma. Johnny Bonadonna went home and then did breast cancer at home. And then, the Fry and Freireich, Emil Fry and Emil Freireich had been at NCI and had started the leukemia field. And then Emil Freireich went to MD Anderson and Emil Fry went to Dana-Farber. But they had been at NCI just not too long before I got there. So everything, that we were doing was informed by them. And then another, Steve Jones was the first person to put AC together. So he had been at Stanford. He'd been at Stanford where, breast radiotherapy and actually I should say lymphoma radiation therapy was born with Kaplan. And so he went to University of Arizona after that and started AC. But the concept of combination chemotherapy in breast cancer, I really think Johnny Bonadonna, and then as you said, Bernie Fisher, he was doing melphalan first, but then very quickly picked up on the CMF. But it's interesting to think about how charismatic and inspiring these men must have been, because they got people to randomize patients, who had breast surgery and have lots of positive nodes, and it's, let's flip that coin of CMF versus nothing. Gosh, either way, it's scary, to give people cytotoxic therapy for a year versus not do anything. Both are scary. You know what I mean? Those were amazing days. At the intensity of these men and their dedication and passion, just completely changed our field, and we are where we are today because of randomized trials.
I mean, not to mention in terms of tough randomization, what about mastectomy versus lumpectomy? I mean, nobody thought you could pull that off in a randomized trial.
Absolutely not. Again, just Bernie Fisher, such a great, great human being. The conviction of the fact of the science, that you weren't going to die of your breast. You were going to die of your metastatic disease that he had modeled in the, he was a scientist. He was in the lab, and he knew you weren't dying from your breast, and that, the horse was out of the barn by the time it presented, basically, and so you could back off on the breast. But again, wow, just conviction, amazing people.
Yeah, I mean, even randomization for preoperative therapy, I mean, that was really the first preoperative therapy, certainly in breast cancer, maybe in oncology. All right, well, let's talk about where we are today. And just to begin, when I was working with Dr. Curigliano, I asked him where he thought things would be in 2 years. This is the only video I want to show. I just want to give a little sample of him. But I asked him where he thought we would be in terms of management of metastatic HER2-positive disease in 2 years. And I'm curious how your thoughts compare to his. Here's what he had to say.
I believe in 2 years from now, potentially we will have a new standard of care in the first-line setting. So in my opinion, the study comparing trastuzumab deruxtecan to pertuzumab, trastuzumab, and taxane will favor trastuzumab deruxtecan. What I would like to understand is if in the post-neoadjuvant setting with residual disease, if trastuzumab deruxtecan will be better than T-DM1. We have to be very careful about the risk of ILD, because in the curative setting, of course, ILD may be a big issue. So we have really to understand how to better recognize patients at risk of ILD.
What about tucatinib?
I believe tucatinib is the more potent tyrosine kinase inhibitor that we have. We have a trial in the post-neoadjuvant setting comparing T-DM1 plus tucatinib versus T-DM1 alone. If in this trial we will demonstrate a benefit in terms of invasive disease-free survival and potentially overall survival, I believe the future will be to incorporate tyrosine kinase inhibitors in combination with the ADCs. Because dual blockade is better than single blockade. So in my vision, tyrosine kinase inhibitor will still have a role both in the adjuvant and in the metastatic setting, because a dual blockade on the extracellular domain and intracellular domain may improve activity of an entire two therapy. And since now we have data that demonstrate that the mechanism of resistance to antibody drug conjugate is the downregulation of the receptor. So giving after an ADC a tyrosine kinase inhibitor may upregulate again the receptor.
So you could probably spend about an hour talking about all the things he brought up, but any thoughts?
I really totally agree with him. I think that TDXD first line will be superior to our current Cleopatra standard of taxane, trastuzumab, pertuzumab, because in the Destiny Breast 03, which is second line TDXD, the median progression-free survival was 28 months. And in the first line Cleopatra, where only 11% of patients had prior trastuzumab, the median PFS with taxane, trastuzumab, pertuzumab was 18 months. So I think that TDXD will be superior. Whether pertuzumab will add, I don't know. I think an interesting clinical question will be, if TDXD becomes the first line standard of care, is how long can you safely give it before you start getting concerned about ILD risk? Because as we know, first line metastatic patients can go for many years on their first line therapy. Will we at some point switch over to a maintenance HP strategy? You know, certainly if there's any kind of ILD grade 1 that comes up in patients, certainly any grade 2, we're going to have to stop permanently, of course, you know. That's going to be something we're going to have to sort out. It'll be interesting to see from the Destiny Breast 09, which is the first line trial Giuseppe was talking about, what percentage of patients randomized to TDXD end up at some point going on to HP because of whatever toxicity that's cumulative with TDXD.
But just to clarify, in the trial, they give the TDXD indefinitely?
Yes. Yeah, we've got that open, Neil. I don't think there's any contingency for switching to an HP as a maintenance. I think if patients have to stop, they have to stop. Of course, they're allowed dose reduction, but if they have to stop, then they're off of the treatment phase of the clinical trial. Docs will have to do what they're going to do for their patients, and my guess will be HP, but those patients will stay in the intent to treat analysis, being censored for progression-free survival at that moment, but available for overall survival analysis.
What about what he was saying about tucatinib? A lot of that was new to me. First of all, the fact that it upregulates the HER2, right? And then the other thing, is that true that it's actually downregulation of HER2 that leads to progression on, like, say, TDXD?
Yeah, so this is a very, very interesting area, and I just gave a talk about this at ESMO Breast, as a matter of fact. Neil, I pulled the slides together, and so in the DAISY metastatic trial in HER2 positive and HER2 low patients treated with TDXD, they did a biopsy of the breast cancer before and after several cycles. It was upon progression on TDXD, and they showed downregulation of HER2 following progression on TDXD in 89% of the patients who had a change in their level of expression of HER2. It went down. So 2/3 had a change, either up or down, in their HER2 following progression on TDXD, and 89% of the people who had a change, it was down. We also saw that in Sarah Hurvitz's preoperative TALENT trial, which looked at TDXD in HER2 low, HR positive, HER2 low patients. They got single agent TDXD, and they looked at HER2 expression on the definitive surgical specimen, and downregulation of HER2 was commonly seen after in the residual disease, in the resistant disease to TDXD. The resistant disease had downregulation of HER2. Now, it turns out that there's other mechanisms of resistance that have been described with ADCs. There's a nice paper from the MGH group published in Cancer Discovery looking at mechanisms of resistance to sacituzumab. And it's very interesting, Neil. There's two mechanisms, and one is loss of TROP2, the target. Just like after T-DXd, there's downregulation, there's less HER2 there. Now, exactly how that happens, we're not sure, but with sacituzumab, there's a mutation that happens in TROP2, the target for sacituzumab, and it doesn't anchor in the cytoplasmic membrane. It floats free in the cytoplasm, so you lose your target. The other mechanism, which also I think is pertinent with regard to T-DXd, is that both sacituzumab and T-DXd target the cytotoxic payload, targets topoisomerase 1. And with sacituzumab, there is a mutation in topoisomerase 1 that doesn't allow the SN38 to bind anymore. And so that'll be, the good thing about that is if we're going to sequence the agents, just because SN38 doesn't mean bind, doesn't mean at all that deruxtecan won't bind, okay? So that may be a non-cross resistant mechanism of resistance, but it's interesting. So yes, Neil, there's data, preclinical data that's quite good actually, with tucatinib showing that whether it be in HER2 low cell lines or whether it be in HER2 positive cell lines, you get upregulation of HER2 expression with the tyrosine kinase inhibitors. The dwell time, there's not as much rapid turnover of the because you're hitting that tyrosine kinase end of the HER2 very strong with the tucatinib. There's more of a dwell time of the HER2 on the cell surface. That has also been shown with lapatinib. Neil Spector showed that and published on that some years back with the HER1, HER2 oral tyrosine kinase inhibitor, lapatinib, showed it preclinically. And there was some small amounts of data, I want to say published by Aaron Goldhirsch, that showed upregulation of HER2 after treatment with lapatinib. And I will tell you, Neil, that the best responses I ever saw with TDM1, and this is why it's relevant even to today with tucatinib, were after lapatinib. In the old days, we had taxane, trastuzumab first line. That's all we had was second line was lapatinib cape. And then all of a sudden came to our armamentarium TDM1. And I had these patients that were on TDM1 3+ years. And I went back and looked what was special about these exceptional responders. And the answer was they had all had antecedent lapatinib. And then when trastuzumab, pertuzumab, taxane came in, and then we went right to TDM1 second, those durable responses of 3 years, they just went away. People would get 6-9 months on TDM1 because after HP, you're downregulating HER2 off the cell surface, and you're not upregulating it with antecedent lapatinib. So the clinically relevant question for today, Neil, is we're going to give T-DXd second line to almost everybody. What do we do third line? I have a strong opinion that we should be given tucatinib triplet third line and saving our TDM1 for fourth line in the hope that patients will benefit, first of all, from tucatinib triplet, but then upon progression, that a mechanism of resistance may even be upregulation of HER2, that TDM1 will work its magic again like it used to work when it was given after lapatinib.
Yeah, I mean, my whole view of tucatinib changed when he told me that. We were working with Sarah Tolaney this morning. I was asking her about it, and the idea, I always used to think of tucatinib, but has brain activity, and maybe that's a good reason to add it on. But this is a whole other venue that's really exciting about the potentiation of these ADCs. Sarah, I don't know if it was a trial or not, was mentioning the potential strategy of using a TKI like tucatinib to try to push somebody from HER2 0 to HER2 1 so you could give them TDXD. Any thoughts about that?
Yeah, I mean, it's a super interesting. I think it's well worth looking at it because in the DAISY trial, I think, Neil, they showed that. I think there were some HER2 zeros in the DAISY trial. And then well, actually, that would not be relevant because that was T-DXd. So I haven't seen clinical data with that, but preclinically, the tucatinib really does increase HER2 expression, even in HER2 low cell lines. And there's two relevant clinical trials going on. One is the HER2 CLIMB-02 trial, and those results ought to be mature pretty soon. That's T-DM1 plus minus tucatinib, largely in the second line setting because it was before we had T-DXd. And then there's a large phase 2 trial ongoing, which is T-DXd plus tucatinib. And so that makes that's very, very interesting as well, because we'd like to optimize the utility of T-DXd for sure. And we'd all like to see both T-DXd and tucatinib in the curative setting because they're better than our chemotherapy and trastuzumab and probably pertuzumab combinations in all likelihood, but also both are brain penetrant. So why not look at them together? Right now, as Giuseppe said, there's separate trials going on, bringing the T-DXd versus T-DM1 in the adjuvant setting in HER2-positive patients with residual disease, and a second line of investigation, T-DM1 plus minus tucatinib in those with residual disease. But eventually, it would be very interesting to see them brought together because it may be that tucatinib does really synergize with the ADCs in general.
So we're getting some good questions in the chat room, but let me ask you also, this is an issue I've been noticing the last couple of years. Actually, we did another symposium at ONS on HER2 across the tumor spectrum. So we had lung people, breast, and GI people all there talking about anti-HER2 therapy. And one of the things that's really interesting is particularly the GI people and upper GI, now HER2's T-DXd, they give trastuzumab first line, or they've been doing that for a while. But one of the things I noticed about the GI people is if they retest people and they go from HER2 positive to HER2 negative, they don't use HER2 therapy. And I think what I see in breast cancer is once you're HER2 positive, you're going to be treated as HER2 positive. Is that the way you think it through?
In the metastatic setting, in the curative setting, yes. We know from the Catherine trial that in patients who had residual disease, these are HER2 positive patients, they received preoperative therapy, they have residual disease, that regardless of the HER2 status of their residual disease, they benefited from T-DM1 more than from finishing up trastuzumab or trastuzumab plus pertuzumab. So in the curative setting, we don't even have to repeat the HER2 on that residual disease in our clinic, because patients are going to benefit from T-DM1 regardless of HER2 status. Now, in the metastatic setting, Neil, there are cancers that are biphenotypic, and you can have heterogeneity of HER2 amplification. I have a patient like this right now, and she's HR positive, HER2 positive, but she's got a subclone that's in the bone that is HER2 negative, and her disease in liver is HER2 positive. So we kind of, I'm using, for example, in those patients, the Monarch-HER trial, which is trastuzumab plus abemaciclib plus fulvestrant. So we're getting both the abemaciclib fulvestrant in the HER2 negative, but you can't leave the HER2 untreated. You have to continue the trastuzumab. And that's true as well. You can have biphenotypic cancers that are basal-like. You can have a basal-like component and a HER2 amplified component. So these are very rare. But they exist. They definitely exist. So I wouldn't say that I always give HER2-based therapy to somebody who was initially HER2 positive. I'll tell you, Neil, in HR positive, HER2 negative disease, some of these cancers are pretty equivocal on their HER2 findings. And when I have these borderline HER2 positive, there'll be 2+, and there'll be low-level HER2 amplification. I personally send all of those to Dr. Michael Press at USC, and many times he doesn't even think they're HER2 amplified. So a lot of things in our standard practice are called HER2 positive, and it's an overcall. We probably have 20% of the time in across the United States in a variety of pathology labs, 20% of the time we're overcalling HER2. That's why all HER2 positive trials have to be centrally confirmed to be HER2. So there's times, Neil, where patients are treated HER2 positive, but in fact, they're really not HER2 driven. And then subsequent biopsies will show HER2 low disease or HER2 negative disease. So I don't always keep the HER2 based therapy going.
Let me read you a question from Anita in the chat room. But first, this case you had where the patient was positive in the liver and negative in the bone, I thought you can see false negative in the bone.
You can, but generally speaking, and particularly if it's been positive in the past, which I don't know that she actually had been positive in the past, but also on ctDNA is another way of checking that. If you're having progression of disease and you're not seeing the HER2 amplicon, then that tells you that resistant disease that's progressing is not HER2, is really not HER2 driven. So, and this patient in particular, she had one of those more low level of HER2 amplification in the beginning. She presented de novo metastatic in the bone, and it was initially kind of borderline, and I treated her as such. And what went to the liver really is HER2 positive, but I've just not been convinced at all that what's in the bone is HER2 positive.
All right, here's the question from Anita. Quote, we're seeing a lot of neuropathy from docetaxel. Many of our patients have high BMI, and if they're young, an AUC of 5 will yield a carbo dose of 600 to 900. Is it okay to omit the carbo with cycle 5 and 6 in patients who are having a clinical response in their tumor if significant neuropathy has occurred, or reduce the AUC of 3 or 4 in patients with stage 2 or 3 disease? She also wants to know, is there any contribution of pertuzumab to neuropathy?
So the first question about neuropathy, and this is assuming the preoperative TCHP, carbo doesn't really cause neuropathy. Cisplatin does, but carbo does not. So if patients are having neuropathy, it's absolutely fine to decrease their docetaxel from 75 to 60 for sure. So, and certainly patients should do cryotherapy. They should cool their fingertips, toes, ball of foot during the 1 hour of docetaxel and for 30 minutes thereafter. There are emerging data, and it can also use tight gloves. There's a trial called the Polar trial that looked at tight gloves, double gloving real tight as a way to clamp down the blood vessels that maybe even be better than cooling of the hands. And one could do both. One could do both, double gloving tight. So docetaxel would be the culprit. Now, trastuzumab and pertuzumab early on do not have neuropathy. I will say that in patients who have been on trastuzumab, pertuzumab for many, many years, we're talking 5 years, 8 years, de novo metastatics, I have 3 or 4 patients who have had cumulative neuropathy with the combination of HP. And so I've stopped the pertuzumab and just kept going with the trastuzumab. But these were in the patients on many, 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 many years of HP, but not in the curative setting, not when we're just giving those 6 cycles preoperatively. If they have a CR, we're giving, 7.5 more months of HP. You don't see neuropathy there from the HP. I've never, ever seen that or had any inkling that was the case.
So a question from Hassan in the chat room, a couple questions. How much efficacy from the ADCs is from the payload and how much from the immune system via ADCC? And he also wants to know any role for anti-TROP2 ADC linked to deruxtecan after failure of TDXD. And I guess maybe that option is going to be coming up in the near future.
Yes. So the first question about the mechanism of action of TDXD, for example, which does downregulate HER2 off the cell surface, of course, because it binds to HER2 and gets internalized. And it is trastuzumab, so it can activate ADCC. But the main activity really seems to be the payload, the topoisomerase 1 inhibitor, the deruxtecan. Now, the thing about deruxtecan, it's a DNA damaging agent. It breaks up the DNA. It stops DNA repair because it really just stops topo 1 and chops up the DNA. It's very difficult for it to repair itself. And that activates the gas-sting pathway. That chopped up DNA seeps into the cytoplasm and activates an immune response. So there probably is, when we see this level of activity, as we see with T-DXd, it's very likely an immune effect as well. Whether it's trastuzumab activating ADCC or whether it's the deruxtecan chopping up the DNA and activating that gas-sting pathway and bringing in those tumor-infiltrating lymphocytes, the CD8s, to kill, it may be a combination of all of the above. So there's a lot of work going on looking at the immune effects of the T-DXds and also of the sacituzumabs, and which, of course, is anti-TROP2 antibody conjugated to SN38, another topo 1 inhibitor, and then we have datopotamab, an anti-TROP2 antibody conjugated, as you said, to deruxtecan. So the issue of how to sequence these is fascinating to me. I am so interested that when I talk to docs in the community, okay, docs love ADCs. They are liking less and less single agent, regular cytotoxic therapy. And so if patients get T-DXd for their HER2 low disease and then they progress, docs are very commonly going on to sacituzumab afterwards. So the target switches from HER2 to TROP2, and those should be independent of each other. And then they're giving two topoisomerase 1 inhibitors right after each other. They're given the deruxtecan with the T-DXd, and then they're giving the SN38 with the sacituzumab. But we don't have any data yet about sequencing those, and one could actually think about the reverse. If somebody's HER2 0 and you start with sacituzumab, and then later on you do repeat a biopsy and it's HER2 low, you could come in with a T-DXd. It's fascinating. We don't have data, but docs are very, very interested, and that's really happening in practice rather than going on to single agent therapy. So the idea of going from one TROP2 antibody to another TROP2 antibody, that makes less intuitive sense to me because of this issue of downregulation of the target or loss of the target. I was telling Neil earlier that there's a paper of interest in cancer discovery from the MGH group of patients with metastatic breast cancer receiving sacituzumab. One patient was resistant from the beginning, de novo resistant to sacituzumab, and they found zero TROP2 expression on her breast cancer. She was null. But another patient responded to sacituzumab and then progressed. And they re-biopsied. They did this deep, deep, deep molecular dive into why the cancer became resistant. They found two mechanisms of resistance in the same patient in different cells. So one was loss of TROP2 on the cell surface because TROP2 mutated and it wouldn't bind any longer to the plasma membrane. It was floating free in the cytoplasm, so the sacituzumab could no longer bind to the TROP2. And the other mechanism, and so there, you wouldn't want to come in with another TROP2 antibody. You don't want to give the patient dato, but you could give the patient T-DXd. But then the other mechanism was the topoisomerase 1 enzyme itself mutated, and SN38 could no longer bind. It mutated in the spot where the SN38 bound. Now there, deruxtecan binds in a different part of topo 1, so there may be non-cross resistance there. So a fascinating time. Trials are going on from a practical standpoint, looking at SASI versus T-DXd, or the other way around, T-DXd versus SASI, and no doubt the datopotamab will also be looked at in these sequential studies.
I was just flashing on the fact that in metastatic bladder cancer, they just had an approval of an antibody drug conjugate, enfortumab plus an IO, in patients not eligible for platinum. And the idea of an IO plus an ADC makes a lot of sense because it's kind of like an IO and chemo. And actually, several people in the chat room brought up the issue of in breast cancer adding an IO to ADCs because of that sort of thinking. Any thoughts on that? And also another question from the chat room. Any information on the anti-HER3? I think that's referring to patritumab. I think we're going to see data actually at ASCO on that. But do you want to comment on HER3 ADCs and also the strategy combining IO and ADCs?
Yes. Peter Schmid updated us at San Antonio. I think it was on the Begonia trial, which is first-line metastatic TNBC, combining datopotamab with durvalumab, single-arm study, and wildly active. The response rate, the objective response rate, 74%, but very, very deep and very, very, very durable responses. And catch this, regardless of PD-L1 expression. Very exciting data. So that's being taken forward into the Tropion Breast 05 trial, which is in PD-L1 positive patients. And so it's going to be pembrolizumab chemotherapy, our standard for the PD-L1 positive, versus durvalumab with the datopotamab. And dato will also be looked at in PD-L1 negative patients. But, one could argue that we need to look at durvalumab and dato regardless, in a randomized trial, regardless of PD-L1 expression. We know chemotherapy upregulates PD-L1 expression. That's known. That's why it's better to give IO with chemo than give IO alone. One of the many reasons, but chemo upregulates PD-L1 expression. That happens when you activate the gas sting pathway. So I think this is and then also sacituzumab is also in the ASCENT 03 and 04 trials, first line. So patients are PD-L1 positive. It's sacituzumab plus pembro versus pembro plus chemotherapy. And then if they're PD-L1 negative, it's saci versus chemotherapy first line. Yeah, the anti-HER3 antibody patritumab is also very interesting. It's an anti-HER3 antibody with deruxtecan. It looks very, very active. We had seen Ian Kropp had presented data last year on the phase 2, and then I guess Erica Hamilton will update it at ASCO. But the waterfall plot is remarkably good, and they select patients with an anti-HER3 antibody. It's interesting, Neil, because HER2 and HER3 tend to keep company. And so it's really interesting, since we're going after HER2, even HER2 low, the question is, and we go after that with T-DXd with deruxtecan, really what's going to be the role for patritumab when cancers become resistant to T-DXd? They downregulate HER2 off the cell surface, at least in some cases. Will going after HER3 in that context really be a benefit? It may be, Neil, that there are patients that are very, very low on HER2, but they have more HER3. And maybe that will be the better agent for them.
Yeah, it's interesting. In lung cancer, they're using it in patients with EGFR tumor mutations who progress on osimertinib. They seem to respond there, but ADCs are becoming more and more of a mystery to me. Let me just kind of bring us back to present day for a few minutes, and before we get to some of the papers from ASCO, just put out to you some of the questions we've been getting about metastatic HER2-positive disease, and particularly some of the things I explored with Dr. Curigliano in the program. And one is the issue of a patient who has prior TCHP and then relapses, and in terms of what the next line of therapy is, and how a time to metastasis affects that. So if you see a patient who relapses 6 months after TCHP, how do you manage those patients?
Well, Neil, I think most of us, if it's more than a year after relapse, would use the Cleopatra regimen, the THP. If it's less than a year, we would not repeat the same because they just recurred very quickly. We would probably use T-DXd, go right to T-DXd. The issue is, Neil, from a practical standpoint, that is so rare. And the only time I've seen it really was when the patient had a cancer that's clearly HER2 amplified. It's usually basal-like in its biology, and there's a HER2 amplicon there, but it's not driving. And those patients do benefit from T-DXd because you're delivering a very powerful cytotoxic payload. They do benefit. So clearly that's the way to go. But there's this very small group of HR negative, HER2 clearly amplified breast cancers that are basal-like in their biology. They do very, very poorly. They recur very quickly. But outside of that, Neil, you just kind of like never see it.
So Thoy in the chat room is curious about ERB2 mutations. As I mentioned, we did this program at ONS, and we had lung people there, and that's who they treat, you know, the HER2 mutant disease, and they're seeing great responses there. Also, they see responses with overexpression, but it looks like greater responses with mutant disease. So what about HER2 mutations in breast cancer?
So right now, and I look for those. I do ctDNA all the time in patients with HR positive, HER2 negative breast cancer as it becomes endocrine therapy resistant. About 8 to 10% of lobulars will show up with a HER2 mutation on ctDNA, and maybe 3 to 5% of ductals. So I think it's a great target. And I think based on the lung cancer experience, that I think T-DXd is a great choice. Now, a lot of these patients are HER2 low anyway, so T-DXd makes sense. But if I happen to have somebody with HER2 0 and she had a HER2 mutation, I'd still give her the benefit of the doubt of T-DXd based on the lung cancer experience. So I think that's a very reasonable option. We have not seen data yet in breast cancer with T-DXd in HER2 mutant, but most of those, of course, who have HER2 will be HER2 low. The other option we have for those patients is fulvestrant plus neratinib plus trastuzumab. The SUMMIT trial was updated at San Antonio last year by Kamal Javari. Very, very nice activity in the HR positive, HER2 negative, but HER2 mutant group of patients. Very, very nice looking waterfall plot. So that's another option for patients with HER2 mutant disease.
So speaking of cell-free DNA and getting warmed up for tomorrow with Dr. Overman for colorectal cancer, what about tumor-informed cell-free DNA in breast cancer, Joyce? Have you done it?
In the metastatic setting, I do it all the time. Neil, I pretty much get ctDNA at the time of the first metastatic recurrence, and I get it at the time of every progression. You know, we're getting more and more targets that we can go after based on ctDNA, like ESR1, PIK3CA, soon it'll be AKT, loss of PTEN. We have HER2. As we've discussed, we also know that the SUMMIT trial, neratinib, fulvestrant, trastuzumab also works when there's HER3 activating mutations. We got NTRK, you know, rarely we can find MSI high, rarely. So our list is growing. And so, but I also I have a few, you know, all of us have a few tricks of the trade. I'll just tell you, if you got a luminal B and it's bad news and it's in the liver and it's bad news, and you find on ctDNA or NGS of the tissue, you find co-amplification of FGFR1, cyclin D1, that's a very bad cancer. But I will tell you that weekly paclitaxel gemcitabine, day 1, day 8, is fabulous. And you can get the patient a lovely response for 2+ years. So I look for, there's certain things, Neil, I've found certain patterns over the years, you know, that I use it. Now, I'm not using ctDNA in the curative setting. You know, some of the bespoke assays that are personalized based on the patient's individual tumors in their primary breast cancer, where they sequence it and then they find like 16 different alterations that's personalized to that cancer, and they look, you can look serially. There's wonderful trials going on. We're going to hear at ASCO. Neil, as we were talking about earlier, we're going to hear from the Penelope B trial, which was adjuvant palbociclib in high-risk HR-positive, HER2-negative patients. That was a negative trial in the adjuvant setting, but thankfully, it sounds like they did beautiful work. They got they got CT DNA. So we're going to have a look at, CT DNA results and patients' outcomes in a very, very large data set. Unfortunately, we do know that patients who have early stage breast cancer, that you start to find the CT DNA, the tumor DNA, these patients do recur quickly. Unfortunately, with HR positive disease, there's about a 2-year lag time. The median was 8.9 months in Charles Coombs's clinical cancer research paper, about 49 patients, HR positive, HER2 negative. The lead time was about 9 months, but some patients were up to 2 years between the time that you found the circulating tumor DNA to be positive and the time of radiologic relapse, recurrence. So this is very, very important. And a number of clinical trials are finding those super high-risk patients and then doing randomized trials to try to clear that CT DNA. There is a paper that's been published now by the I-SPY group, very, very nice, looking at patients at the time of their diagnosis of locally advanced stage 2-3 breast cancer going on to the I-SPY trial. You have to have a high 70 gene mammoprint to qualify, mixed subtypes. And if these patients had ctDNA positive at diagnosis, if they cleared the ctDNA, they did well. And they did as well as not having any ctDNA in the beginning. But if they did not clear that ctDNA, they all recurred very rapidly within a couple of years. So clearance of ctDNA may end up being a very important endpoint in these trials. And I'm cooking up a trial to do myself to find those patients and to intervene to see if we can clear, because you can do pilot trials of in single arm pilot trial looking at clearance as an endpoint.
You're cooking in general. You've been cooking for a long time, Joyce, and I think you're the league leader in tricks of the trade, incidentally. I was doing a program with an investigator yesterday, and she goes, back in the day in 2019, I'm like, yeah, yeah, that's right.
Yeah, it's the old,
all right,
old people that have the tricks.
The old day, right? Yeah, right, exactly. All right, so just take a quick look at. I just pulled a few of the papers that are coming out that I was interested in. Here are some HER2 papers. This is interesting. I'm not sure I've seen much on this. Last year at San Antonio, we presented two 87-year-old and a 90-year-old who responded to TDXD, and the doc started a lower dose. But I've been curious whether there's any data. I guess we're going to see some data on the impact and even including safety with based on age, some more data on HER2 low, and now you see the HER3, the patritumab that's going to be presented. Any thoughts about age? If you had a 90-year-old, would you start out a lower dose?
Oh, definitely. In the meta-analyses that have been done with TDXD, looking at risk factors for ILD, one that comes out is renal function. So substantially diminished renal function falls out as something to be aware of, that patients can get a higher risk for ILD. And of course, really older people, octogenarians, nonagenarians, these folks, these women have less renal function. So I definitely would start at a lower dose, Neil, for sure. Probably at a 4.4 mg per kg, and then go up to 4.4 if they were, I'd be very, very cautious with that. But and the same is true with these days with abemaciclib. I find that older women, and the Monarch E trial, older women over the age of 65 did have a higher chance of needing a dose reduction. They benefited equally from the adjuvant abemaciclib, but they had a higher chance of needing a dose reduction. So I do, and when people are very elderly, I always look at the renal function anyway, because if people have renal, their creatinine clearance is 60 or less or 50 or less, I'm pretty cautious anyway, because you really don't want people to have a bad experience right out of the starting gates.
So we were talking before about legends in oncology, and Dr. Dennis Slayman certainly is been a legend for a long time, particularly in terms of HER2 positivity. Here he is presenting the Natalie study, another adjuvant CDK study that we know from press releases positive. I guess these are a lower risk patients. It was interesting too when you were talking about the origin back in the NCI. There weren't too. I didn't hear much about women, and nowadays, a lot of women investigators in breast cancer and oncology in general. And then we're going to see some more data from ABEMA. Any thoughts about where we're going to be after ASCO in terms of adjuvant CDK, Joyce?
Well, I'm participating in, with you, Neil, at ASCO breast cancer and a couple of other, discussions and advisory groups, and I cannot wait. It's going to be fabulous to see the Natalie data, and it's the high-risk group, similar to Monarch E, but it's also an intermediate risk group. So it'll be fabulous. Now, obviously, in the intermediate group, we'll only have ribo once it's approved, so we'll be using that. But what about the high-risk group? And, it'll have a shorter follow-up than Monarch E. Monarch E, we're out to median 42 months. We have mature data, 4-year IDFS now. We won't have 4-year IDFS in Natalie yet, but are the curves tracking each other at that time point? The intermediate risk group will make it be such that there's fewer events because they don't have as many events. But so to do apples to apples, we'll have to look at the high risk group, the Natalie patients that would have been eligible for Monarch E, and see if the point estimates for IDFS are tracking each other at that time. So this is going to be very interesting. The fact that it's 3 years of treatment as opposed to 2 years may also mean fewer events because patients are not stopping the ribociclib for 3 years time. So there's going to be a lot of nuances around these data, but I think the bottom line is that it'll be welcome to have a second adjuvant CDK4/6 inhibitor in the clinic, give doctors and patients choices. But at the end of the day, for the high-risk patients, the Monarch E data are very good. You know what I mean? They're very, very good. And so for the high-risk patients, we're going to have to be convinced that the Natalie data are as good, really in the high-risk patients.
So we were talking about anti-HER therapy 2 years from now. Give me your prediction for adjuvant CDK, maybe 2 to 5 years, because I think we're going to be giving it to node-negative patients. I mean, risk-benefit, if you apply the hazard rate down, it seems like it would make sense in some select patients in lower risk. Am I wrong?
No, I think you're right, Neil, because some node-negative patients have considerable risk. No question about it. Larger cancers and very highly proliferative biology, grade 3, genomically unstable.
Oncotype.
Yeah, oncotype is another one. Yeah, absolutely, Neil. And there's a study starting up. It's a registry trial called the WIDER trial, WIDER eligibility with adjuvant ribociclib that actually includes more in the way of node-negative patients. The Natalie trial also includes very high-risk node-negative patients, but the WIDER trial will open it up to more intermediate risk node-negative patients. So I think you're right. I think that's where we're going to end up, Neil.
I mean, I don't see CDK as necessarily that much more toxic than endocrine therapy. And endocrine therapy, we don't just restrict it to high-risk patients.
Right. So, no, I really do think you're right. I think that patients who have residual risk, certainly that's 10% or more, we're going to take that hazard ratio of 0.6 and get those, 4 points. The interesting thing about Monarch E is that with every passing year, the hazard ratio deepens and the absolute benefit increases. Let's hope that happens right across the board with ribociclib as well. And so then, and patients will take 4 or 5 absolute percentage points in IDFS. Some patients will take 2 or 3%. So that'll be a discussion down at the lower ends. But I think you're right that anybody who has enough residual risk, and certainly 10% is enough in my mind, that they should be offered it.
Yeah, I mean, that's what we're doing in endocrine therapy, and it's based a lot on, interestingly, we're going to see some more data from the meta-analysis that we've been seeing data for like 40 years, I think, the group in Oxford. I actually went to one of those meetings at Oxford one time with Richard Pito. It's pretty cool going over there to Oxford. But anyhow, they're presenting some data in younger patients, premenopausal patients. It should be pretty interesting, and then there'll be a discussion about management. Any thoughts about ovarian suppression, ablation in the adjuvant setting? One of the things that we just saw some updates from the Soft and Text trial and an editorial by Kathy Miller. One of the things they didn't mention that we see in our surveys is deciding when you're going to use tamoxifen as opposed to ovarian suppression plus either tamoxifen or an AI. And one of the things they don't talk about in the guidelines, but we see it when we ask people, is that actually oncotype drives some of this. So, you know, the people you're thinking about tamoxifen alone are going to be node negative. Generally, at least in the United States, they're going to get a genomic assay, probably the oncotype. And what we see is if people see high, you know, if they're going to give chemo for node negative, they're going to make sure they're going to do ovarian suppression plus. Is that sort of the way you do it?
Yeah, I have a very specific way. And I think I've said this. I think a lot of docs do what I do. Remember in Taylor X that patients who had a recurrence score under 18, the old cut point, wrong, 10 or under, they had 5 years of tamoxifen alone. There were virtually no recurrences. So we have level 1 evidence from Taylor X that if you have a very low recurrence score, tamoxifen is fine. Now, there's caveats there. We know from Soft and Text that patients under the age of 35 with tamoxifen alone do very, very poorly. Tamoxifen probably has limited benefit in those under 35. If you look at the original publication of Soft and Text, rapid recurrences, even though these under 35-year-old patients, 90% of them plus had chemotherapy, very, very poor with tamoxifen. So not everybody, not the super young, but patients who are, over 40, for example, if they have a very, very low recurrence score, 10 or under, I'm comfortable with tamoxifen alone. If they're between 11, so what I do is between 11 and 16, there's no benefit from chemotherapy there. Those patients do very well. I will discuss plus minus an LHRH agonist there. It depends on the overall clinical pathologic features of the cancer. But if they are 16 to 20, I will offer the patient an LHRH agonist plus AI. And many times no chemotherapy. But if they're 21 or above, I'll give them chemotherapy and an LHRH agonist plus AI. So I kind of parse it out, and I write it down for patients when I see them exactly. Of course, you put in the clinical pathologic features, and for node negative patients, the RS-CLIN can help a lot because it incorporates not only the 21 gene recurrence score, but it incorporates the key size, grade of the cancer as well. For node negative only, doesn't work for node positive, not validated. So I do exactly that. And I know the guidelines don't address that, Neil, because in the Soft and Text trial, we haven't seen data based on the 21 gene recurrence score. And we haven't seen in the Taylor X, we haven't seen, there was so few patients. It was like 13% of patients that got an LHRH agonist in the Taylor X. That's why we have to do the, NRG 09 trial and give everybody LHRH agonist plus an endocrine agent versus chemotherapy if their 21 gene recurrence score is under 25, node negative, or 1 to 3 node positive, because there wasn't enough use of LHRH agonists in the responder and the Taylor X. And so it looks like everybody who's premenopausal benefits from chemotherapy. But that's not going to be true. It's going to be that chemotherapy is causing ovarian ablation in these trials. And so if you give the patient LHRH agonist plus an AI, they don't need the chemo. But we need the randomized data from NRG 09 to answer that question.
So here are three more papers from ASCO that I thought the audience might want to keep their eye on. We already talked about the circulating DNA. One thing I want to ask you about this, there's another paper there with ESR1 mutation, but one sort of clinical question I'm curious about, which is how do you deal with patients who have both PIK3 positive and ESR1 mutant, and will that change if and when capivasertib is approved?
Well, and that is a very practical question, and I tend to favor elacestrant as a single agent for the ESR1 mutant population if the patients, I think, have a reasonable window of opportunity post-progression on CDK4/6 to go with a single agent endocrine therapy, because of course the toxicity with elacestrant is a lot less than with alpelisib. Conversely, if the patient progresses on CDK4/6, has a PIK3CA mutation, ESR1 mutation, and they have more aggressive disease, very painful bony metastasis, more aggressive liver disease, I will go with combination therapy with the fulvestrant and the alpelisib. But I would certainly go back at a later time and inhibit the ESR1 mutation. Sometimes patients who benefit from inhibition of the PI3 kinase pathway, whether it be with everolimus, whether it be with alpelisib, when the disease progresses, they can escape through the estrogen receptor through this mutant ESR1. So that may be quite the opportune time to go back with elacestrant. So I go both ways, Neil, depending on the virulence of the disease.
So Joyce, thanks so much for working with us today. Looking forward to seeing you at ASCO. Audience, thank you for attending. Come back tomorrow night. We'll see what Dr. Overman has to say, particularly about MSI high disease, where he's done so much interesting research. Be safe, stay well, and have a great night. Thanks so much, Joyce.
Good night, everybody. Thanks so much. Bye-bye. Bye-bye.